Hi, I'm Dr. Tony LaPorta, presenting for my young colleague, Alexandria Barton. I am a professor of surgery and military medicine at Vista University and a senior retired Army colonel. Dr. Barton is currently involved in military training that was changed because of the COVID virus. We have nothing to disclose, and our entire team is grateful for the opportunity to present this at SAGES military meeting. As we all know, gun violence has become a daily reality in our society, and multiple events have occurred many times now. And unfortunately, here in Denver, we appear to be near the top of all lists that has catastrophic multiple school shootings. We believe that because this reality has changed, that we must change our training also and change the way we respond to these events. Such things as where should we train, how do we train together, and do we train for real are all important in how we do this. We need to train in the field. As you see here, SWAT team approaching. We need to train not only in the site of injury and quickly stop the bleed, we have to train along all lines of the pathway to the operating room and recovery room, including as here in the elevator. We need to train in the operating room as a team for much more catastrophic disease. As you see here, Reggie Francios, the operating surgeon, has his entire team catastrophically addressing the terrible problems that many of these patients have. We have developed, sorry, the wrong way on the slide, we have developed a method of having our law enforcement responsible for placing the initial bleeds, and we have moved on to what is now called the warm zone training and the training for our police officers, fire and EMT, our hospitals, our logistics, our operating room staffs, our radiologists, our everything that has to do with the logistics and stopping the bleeding and getting the patient to the operating room, as discussed by Lenworth Jacobs in the Hartford consensus. So the way we did that was we set up what is the largest multi-unit training that we have ever set up. We had a total of 910 EMTs, paramedics, firefighters, law enforcement dispatchers, law enforcement officers, SWAT, emergency personnel, the emergency room, the hospital respiratory, the hospital logistics, the hospital operating room. Hospitals would close down one half of the ER and give us 2 operating rooms to carry out these. This is all possible because of the usage of the new training device called the partial task trainer, called the cut suit, where it places over a human being and allows you to have all of the anatomically correct organs so that you can go and perform all of the necessary procedures such as cricothyroidotomy, needle decompression, chest tube, even damage control surgery and thoracotomy. So we did this in 9 days, twice a day, each particular time having 7 critically ill patients, sometimes up to 20 patients total, but 7 critical, that allowed us to test the system for real. So we had everybody involved in an event that would move us into the direction of competency, and especially find out where the multiple glitches are in any of these situations. So at the end of the day, we had 574 firefighters and EMTs and paramedics, excuse me, 70 law enforcement officers, 170 mid-level providers such as nurses and PAs, 40 physicians, everything from the ER and chief medical officers in the operating room, 30 dispatchers, and 26 responders that were either from the very large churches that also had schools involved in them, and the areas that were involved were 3 churches that were actually all within about 4 miles at the most from the STEM school, which is the location of our most recent mass shooting. So once again, just to show you how many procedures were performed and who did them, we had a weekly total of 112 patients that were received a total of 480 procedures, such as cricothyroidotomies, tourniquets, PAPs, and everything. And to say this allowed us to work out the logistics of all the events would be an understatement. The most important part, I believe, in all of this is that you must actually use the equipment, or at least go get the equipment, so that you know where it is, that you really have it. And you, of course, do have to make sure that you know how to use it. And all of these mistakes have been made many, many times by all training people. So the results were that in our Operation 9 Minutes, which was an active shooter drill, 6 months later, within a mile of one of the churches, the real event occurred. 9 victims. The first was a 13-year-old young woman who was bilateral femoral tourniquets placed in 2 minutes and 17 seconds from the first shot, placed on by a police officer who had saved his own life a year earlier by putting a tourniquet on himself in a different shooting. The first child was transported in 5 minutes, and all children were gone out of the building by 16 minutes, except for the young man who died on the scene. This you can compare to 47 minutes, which was the first time even a person went into the building at Columbine. So the real strengths and weaknesses here were identified by all the participating groups, both pre-hospital and in-hospital care. Again, think logistics. This in situ training is the only way to actually have habituation and solid training. This is your challenge. These hospital corporations are making huge profits, yet tell us they can't afford to train and save lives for our community. My answer is, I don't buy it. Please, please push and try to get your own areas trained up as a unit. It took a judicial act here in Colorado for us to pull this particular event off. But at least the state recognized it. Thank you for your attention.